Good evening, everyone, and welcome. Thank you for joining us tonight for the kickoff of our educational webinar series for 2025. Before we begin, just a few reminders. I know many of you are familiar with the SAB's platform GoToWebinar, but we ask that you put your questions or submit them through your control panel. There is a question feature there. Dr. Pilli will get to them with Dr. Ahmad at the end of the presentation. At this time, I'm going to hand it off to Dr. Ahmad, who sits on the SAB's Education and Program Committee, to introduce tonight's speaker and the topic. Thank you again for joining.
Thank you, Doctor. Thank you, Emily. Good evening, all. It is my pleasure today to introduce Dr. Suchitra Pilli. Dr. Pilli is board certified by the American Board of Internal Medicine and in interventional pulmonology and critical care medicine. She specializes and practices the breadth of interventional pulmonology procedures, and she also works with lung cancer screening and lung nodule management in Phoenix, Arizona. She currently practices at Honor Health Medical Group. She's a diplomat of the American Association of Bronchology and Interventional Pulmonology and a fellow of the American College of Chest Physicians. Dr. Pilli takes an integrated approach to patient care, focuses on building strong relationships and caring for the whole person. In her free time, she also enjoys driving fast cars. Once again, it's my pleasure to introduce Dr. Pilli. Dr. Pilli, welcome.
Thank you, Danish, for the kind introduction. And I'm going to jump right into it. So this is an important topic, I think, molecular biomarkers in lung cancer. And my disclosures are on that slide. So firstly, I think, we have to talk about why should we even talk about biomarkers as pulmonologists and interventional pulmonologists. And, I'm going to delve a little bit into diagnostic biomarkers that we can use in evaluation of a lung nodule and treatment implications of biomarkers in lung cancer that have been evolving very, very rapidly in the last decade. And should pulmonologists even know about lung cancer biomarkers? Is it an oncology domain? Next-gen sequencing has been their domain for quite a while, but should we know about it? And then what is an interventional pulmonologist's role in all of this evolution in the treatment and diagnostics in the field of lung cancer? So we'll jump right into lung nodule risk stratification. So, predominant practice of my outpatient clinic is lung nodules, and all the way from, we get 3 millimeters to 40 millimeters or lung masses of all types. And how do you risk stratify? How do you really approach this? And the key words that I like to, really use almost in every patient note is, what is the pre-test probability of this lung nodule to be something of concern to us, which is primary bronchogenic carcinoma or a metastatic lesion, right? And jumping into the two biomarkers that are available, FDA approved, I sometimes use these in the appropriate patients. Now, Notify CDT is a test that is available, and it technically rules in cancer, or it raises the risk of malignancy. And the test has been, studied, and 5% of the patients are then reclassified to more than high risk. So if you get a patient that is intermediate risk on your Mayo or Brock models of risk calculator for the lung nodules, and you use the Notify CDT, about 5% of those patients are reclassified to high risk. And those patients you might want to pay special attention to and consider a change of plan as needed. Some criteria that have to be met for this particular test is 8 millimeters is the minimum nodule that was studied. So I stick to 8 millimeters to 30 millimeters when I use it. Sometimes I have sent it for a 7 millimeter nodule, and if it reclassifies it to high risk, great. And if it doesn't, my plan does not depend on the result of that test. The patient has to be at least 40 or over. Pretest probability 0 to 65% at a minimum. If it's already above 65%, this should not be used in that particular patient, and no prior history of cancer. It tests for 7 different autoantibodies to cancer. I'm not going to pronounce or read through those, but you can see it. What I would focus on is if it is positive, the specificity is almost 98%. So if it does not reclassify a particular nodule to high risk, I would move on from that because the positive predictive value is reasonable but not very high. So this is a slide that kind of tells you it raises the risk of malignancy for lung nodules that are likely malignant. 7 autoantibodies on the left side, 98% specificity, 78% positive predictive value. So 4 out of 5 of these results are cancerous. 2% of benign nodules will receive a CDT high level result. So this is not very positive. Most of the time I expect it to come back not reclassifying patients, because those are patients who already have pretest probability that is high to begin with. So I would say this is a rare test that I ever send. Now, biomarkers, again, moving on to the second type of biomarker available, the Notify XL2, which lowers the risk of malignancy, right? Almost 35% of patients are reclassified to being under 5%. So now we are getting into an area where the percentage starts to matter a little bit, and maybe there is some help that you can get from this particular test or some information. Now, Notify XL2 is available, but really it depends on a combination of clinical factors and some plasma proteins that are listed there. So age of the patient, size of the nodule, location, speculated versus non-speculated, history of smoking, and then there are 2 plasma proteins that are studied, and the sensitivity of the test is 98%, and the negative predictive value is 98%. So here I would focus on that negative predictive value, which is pretty high. So if it is, and the sensitivity being about 98%. Now, the criteria, again, about the same, 8 to 30 millimeter nodules, more than 40 years of age. The pretest probability has to be at least 0 to 50%. If it is more than 50%, we should not be sending this test to try to reclassify them to a lower percentage of risk, right? If it's more than 50%, we should be acting on that. Patient also should not have any history of lung cancer or any cancer in the last 5 years. 20% of results, which is pretty high number, right? So at least 1 out of the 5 tests that you're going to send will come back as indeterminate. And those are the cases where, I pretty much act as if I have not sent this particular test on the patient, and you go back to your pretest probability, whether that was physician judgment based or whether a calculator based, and use that. So interestingly, the 2 proteins they measure are the LG3BP and the C163. The one on top is increased in lung cancer. The one on the bottom is increased in inflammation. So Notify XL2 is nothing but the combination risk, the combination ratio of these 2 proteins, along with the 5 clinical factors that I went over, both of the patient characteristics and the nodule characteristics. The smaller the ratio between the top and the bottom proteins, the more likely the nodule is benign. So what it does is it reclassifies things to benign. This is how a typical result is going to look, test results and interpretations. If it might say likely benign and drop the risk to under 5%, and reduced risk and likely benign are the 2 options you might get. And if it's indeterminate, I would just completely ignore that test at that point and follow your own, either physician judgment or a pretest probability risk, and the further steps should be based on that. So I'm going to give a couple of outpatient cases that I've used this in. These are all my patients, and see how these may be applicable in your practice. Case 1 is a 77-year-old female, never smoker. She had an episode of DVT and she got a CTPE study, some incidentally detected lung nodules. So in the left lower lobe, there were 2 lobulated non-calcified nodules, 2.1 centimeter and 1.1 centimeter. The Mayo Solitary Pulmonary Risk Calculator said about 24% pretest probability for lung cancer. PET-CT SUV was 3.0 in the 2.1 centimeter nodule and 2.2 in the 1.1 centimeter nodule. Now, post-Notify XL2, the biomarker assigned the risk to about 15%. So it didn't reclassify to less than 5%. What was the outcome, right? I mean, discussing with the patient, going over the PET-CT scan, again, the pretest probability was pretty high, but it's really shared decision-making at that point. It did not reclassify to less than 5%, but alignment of data is what we're looking for in this particular case. So I discussed it, patient felt a little bit comfortable, and we are doing CT surveillance at this time on this patient. I recently moved to Valley Fever country, and a lot of you live in different parts of the country where granulomas are possible due to several different reasons. in a never smoker female. We're going to watch this with a short-term follow-up CT scan, less than about 8 weeks is what I'm going to say. 3 months seemed a little bit too much. This is not a guideline, but that's what we decided on because patient really was trying to avoid a biopsy. Would I have biopsied this? I think if there was any other risk factor or patient had a smoking history, absolutely. So this is her Notify XL2. This is how it looked previously, 24%, and it says reduced risk, but didn't reclassify it to a very low risk category. And we did send the CDT on this patient. Again, no significant antibodies were detected. Again, don't take this with a pinch of salt for what it is worth in this particular patient. Case 2. Case 2 is a 75-year-old female, also outpatient, former smoker, 37 pack years, and her CT chest with left upper lobe 9 mm spiculated nodule. The Mayo Solitary Pulmonary Risk Calculator, as expected, 47% pretest probability. We did not do a PET CT scan. The Notify XL2 was sent on her, and the biomarker risk assessment afterwards was no change. Would I have sent it in retrospect? Probably not. This actually got sent prior to me seeing the patient, and I included it, for all of the information available. And the post-CDT risk assignment was no antibodies were detected. Again, take that with a pinch of salt, and the outcome was she got a robotic bronchoscopy. The result was a granuloma. Again, going back to pretest probability, left upper lobe spiculated nodule, and 37 pack years of smoking history. This really is something that we should take to biopsy at this point, but was a granuloma. This is her Notify XL2, 47%. If you probably a good example of when you don't send this test, to be honest, right? 47%, and it's indeterminate, and this is a case that I would not use either of these two, and I really wanted to bring it up to say this is a patient I wouldn't be sending Notify XL2 or CDT test. Now, case 3 is a 67-year-old female, 14 mm right upper lobe nodule, history of coccidiomycosis in the past. The Mayo Solitary Pulmonary Risk Calculator said about 16% pretest probability, no PET CT scan available. Notify XL2 reassigned this patient to 3%, and the post-CDT, there were no antibodies detected. So now the data is trying to align a little bit, and the outcome of the appointment was, we're going to do a 2-month follow-up CT scan, and then the patient requested a PET scan, as well as an oncologist that she's already following up with. There was no change in size on the follow-up PET CT scan. SUV was 1.3, likely benign. We're going to continue surveillance. So in this particular case, I think the Notify XL2 did help. It reclassified the patient from 16% to 3% and reassured the patient that, for the next 2 months, we're going to watch this nodule. And the 2-month follow-up PET CT scan also aligned with everything, and she's on surveillance. And this might be the one case where I will say we avoided a procedure because a 14 mm right upper lobe nodule staring at us is very hard to resist with a robot. This is Notify XL2 again, 16% risk of malignancy, reclassified to 3%. Same patient, this is her CDT report. All right, so I want to shift gears a little bit from the 2 FDA-approved markers that are already on the market that we went over in quite some detail to a little bit of R&D. So there are other biomarkers in research and development, and Percepta was a test that was previously available, and you had to brush the anterior wall of the right main stem and collect some cells and cut the brush and send it off, and you would get this test result back, whether it is suspicious or non-suspicious, and kind of went out of use a little bit. And because if you're doing a bronchoscopy and you're putting the patient under anesthesia, might as well get the nodule, and it's become easier with all of the technology available. The Percepta nasal swab is something that is interesting, and it's an RNA whole transcriptome expression data from nasal epithelial cells. It is collected with a cytology brush, and some clinical factors are also added to the data that is collected. So you have some biomarkers and you have clinical factors. There was an abstract that was published in Chest 2024, 598 patients smoking or previously smoked. Average nodule size was about 17 millimeters. with about 7 months of follow-up. It is still an ongoing study. The final results have not been released. And lung cancer was detected or diagnosed in 43 patients total in that cohort, 7%. 25 of the 43, 58% of the nodules were labeled as high risk by this classifier, and compared to 37% for physician-assessed risk of lung cancer. So we're comparing how did this biomarker perform when compared to physician-assessed risk of classifying something as lung cancer. And the classifier then also labeled 42% moderate risk, and including three malignant nodules were less than 8 millimeters in size. None of the malignant nodules were labeled as low risk. So far there is a signal in this study that might say that this is something to look forward to and see what the data is going to come out. It is a genomics-based marker. Additional diagnoses are expected in this cohort. It's a longitudinal 2-year surveillance study, and the true sensitivity will be reported when it's fully completed. Now, the use of the classifier in patients who smoke or previously smoked, the clinical implication of that is that it could improve risk stratification, minimizing likelihood that a malignant nodule will be labeled as low risk. So it does classify malignant nodules as malignant in nature. So more to come on this, but something to look forward to is a nasal swab that will give you lung cancer nodule risk stratification. Shifting gears a little bit from diagnostic perspective to lung cancer management. Biomarkers play a role all the way through in lung cancer, right? Risk stratification, staging, treatment, and non-small cell lung cancer. So patients across multiple stages need biomarker testing. This is the age of precision medicine, very inconsistently obtained in many health systems. I've been in a few different healthcare systems, and it is usually very oncology driven, but the landscape is changing a little bit. It is changing to earlier on stage shifting and diagnosing patients early on, and therefore trying to get the biomarker testing early on as soon as the patient is suspected or has a positive, even a positive slide in your bronchoscopy suite might be the time to start. Gathering information specific to a patient's tumor and resectable and non-resectable non-small cell lung cancer with upfront comprehensive biomarker testing is probably going to be the norm in the very, very near future, if not already the norm in many places. Now, targeted therapy and immunotherapy have completely changed the landscape of non-small cell lung cancer and survival. And biomarkers are relevant both in the metastatic and early stage lung cancer treatments. And really, there are two main categories when you talk about these biomarkers. There are the sensitizing mutations, and then there's the oncogenic driver mutations, which will direct the use of targeted therapies and immune therapies on cancer cells to direct, one's own immune system to target cancer cells. So a little bit of, what are actionable biomarkers in lung cancer, right? More than 60%, just to bring it to perspective, more than 60% of patients with non-small cell lung cancer have actionable mutations. I've listed a few of them there, and we're adding more and more. And for the latest staging of non-small cell lung cancer change that has come about is, we're getting into the nitty-gritty of the N2 disease as well. Is it single station versus multi-station? And not only that, adding biomarkers to that, I think that the guidelines are going to be changing in the next 5 to 10 years for sure, to include biomarkers and targeted therapy and immunotherapy even earlier on in the disease as adjuvant treatment. EGFR, KRAS, BRAF, HER2, ERBB2, ALK, ROS1, NTRK, RET, and MET. All of these are actionable mutations that have drugs. On progression of first-line therapy, specific resistance mechanisms can now be checked, right? So you can have MET amplification that happens in your EGFR positive non-small cell lung cancer would then be actionable. And then next-gen sequencing is kind of standard of care at this point. Should you be doing this as an interventional pulmonologist? Absolutely, I know places where we can implement this. I've talked to oncologists where I practice, which is now a large community system with 9 different hospitals and several oncology groups, a little bit different than a tertiary care center. And I've talked to several groups, and they all use different different types of next-gen sequencing systems, right? So if I get a positive call in the Bronx suite, should I be sending them is something that all of you should think about and see what the feasibility of that might be. Again, measuring expression of PD-L1 definitely predicts responsiveness to immunotherapy. We all know that very well. So tissue acquisition-wise, how do we apply that? I've completely adopted cryobiopsies in all robotic, bronchoscopy. So we do the initial slides, but then we move on to cryobiopsy to give ample tissue. And I've had really, really good feedback from pathology. Just started doing that about 4 months ago. Pretty much in every case. EGFR and ALK expression definitely predict a poor response to immunotherapy. So more PD-L1 is good, more EGFR and ALK. They do have targetable therapy, but probably a poor response to immunotherapy in those patients. Consider implementing some sort of biomarker testing at bronchoscopy with ROSE, or at least talk to your pathology groups to say, can you reflex test? And I'm actually actively having these conversations with them to say, if you're making a call, can we start sending those samples by pathology or by the oncologist right at, at that point? Even waiting about 3 to 4 business days and then waiting 2 weeks for the report seems like a little bit of a delay if you want to get them to surgery as quickly as possible. So a little bit about oncogenes and tumor suppressor genes. Now, EGFR is a very key gene in the pathology of lung cancer. Like we said, about 58% of cases, or almost 60% of people have EGFR mutations when they're initially diagnosed. And mutation leads to constant activation of these signaling pathways, uncontrolled growth of cells. That's how the EGFR gene activation causes non-small cell lung cancer or contributes to that. Now, the KRAS works a little bit similar to the EGFR gene mutation, but it is a GTPase enzyme, and it is involved in a high proportion of cases as well. And the role is to produce a protein called KRAS protein, and that regulates the division of cells via the RAS and the MAP kinase pathway. So KRAS and EGFR lead to activation of signaling pathways in cancer when they are activated. Mutation in the KRAS gene, again, the division of cells occurs in an uncontrolled manner. So both EGFR and KRAS mutations are driving the division of cells in an uncontrolled manner. So that's how they work. Now, carcinogens or exposure to carcinogens will increase the rate at which such somatic mutations occur. We know that there is an established relationship between carcinogens and cigarettes, carcinogens that play an active role in several different cancers, and these mutations occur, or they're more, you probably are prone to these, but with those exposures, they're almost a summative effect on whether that happens or not. And they definitely drive all targeted therapy in non-small cell lung cancer at this point. So some other mutations I wanted to talk about is the MET and the BRAF and the ALK and RET and ROS1. We're not going to go into details, but these are all actionable mutations. The more tumor boards I attend, the more I know that these are going to come up, and these are things that we talk about now for these patients. Absolutely, when they come back and they're stage 2B and above, we start talking about these, and it is important for us to start to get educated about them to see how we can play a role with oncology in stage shifting lung cancer. And then P53, that's an interesting one where P53 works a little bit differently than these other mutations, where it provides instructions for making a protein. The name of the protein is P53. It is located in the nucleus of cells all over the body. The P53 attaches directly to DNA and regulates cell growth and division, basically by monitoring DNA damage. So if DNA is damaged, or P53 is the protein that will determine if that DNA is going to be repaired or that cell is going to go into an apoptosis cycle. So if the cell's going to die or is that DNA is repaired, kind of dictated by P53. So when P53 does not work, then that leads to cancer also. So there are some interesting mechanisms there that I just wanted to touch. And these are, we're going to kind of get just an idea of, this is actually from 2016, and the updated version has had more drugs added to it, and I can't even remember the name of all of these drugs, and I at least try to remember what group they belong to when I attend tumor boards to try to know what kind of drug would be effective in this particular mutation. So this is very, very interesting. EGFR sensitizing. Also, there were like 2 drugs when I started fellowship, 9 years ago, and now there is a whole gamut of these. ALK is EGFR used to be, erlotinib, afatinib, osimertinib, and then ALK used to be mainly alectinib and crizotinib, and then there's so many of these new ones. The last version of this that I saw, there are probably another 10 drugs that are added to this list. So MET, HER2, ROS1, BRAF, RET, and the other ones that are probably less. Even though we have so many of these targets and biomarkers in lung cancer, the unknown oncogenic drivers are still about 30 to 40%. So, there's a lot of lung cancer that we cannot treat with targeted therapy. And those are patients you want to think about PD-L1 therapy to see if their immunotherapy might be an option for them, especially in the advanced stages. Now, talking about adjuvant therapies as well, initially, I think the guidelines are starting to incorporate some of this. And I think, as future guidelines for NCCN start to change a little bit, we're going to see a lot of these things come earlier on as adjuvant therapy. That's my thought process there. But the 2018 IASLC guideline for molecular testing of non-small cell lung cancer, all advanced lung adenos have to be tested for EGFR, ALK, and ROS1. So this is something that your oncologist is doing for everything that is adenocarcinoma, because you have to use targeted therapies because they're really the best outcome at this point, and survival as well as side effects. PD-L1 immunohistochemistry is required for guiding immunotherapy. There are other immunotherapy targets now, but I'm not going to go too deep into that. I wanted to bring up something that is very, very recent data. It's called the LAURA trial at the ASCO meeting in 2024 for stage 3 EGFR mutated lung adenocarcinoma. So very, very specific population of patients. It was a randomized, double-blind, placebo-controlled, multi-center global trial, phase 3. Patients were unresectable, and these patients whose disease had not progressed following their definitive platinum-based chemoradiation, right? So normal stage 3 EGFR mutated non-small cell lung cancer, we still, as of now, treat with chemo XRT upfront. So platinum-based chemotherapy followed by, radiation. These patients in this particular study were actually treated with osimertinib once daily until they actually achieved disease progression or unacceptable toxicity or discontinuation criteria were met that they set in this study. Now, they're studied about 216 patients in more than about 145 centers, 15 countries. The US is one of them. And the analysis of the primary endpoint was progression-free survival, right? This trial is still ongoing, and we'll continue to assess the secondary endpoint, which is overall survival. But osimertinib, which is the EGFR TKI, we saw it was in the list of the EGFR TKIs, or tyrosine kinase inhibitors. It reduced the risk of disease progression or death by 84% compared to placebo, right? So this is phenomenal data about stage 3 EGFR mutated lung cancer, where the hazard ratio was 0.16, and you can see the confidence interval is pretty good. But the median progression-free survival was 39 months in patients treated with osimertinib versus 5.6 months for placebo. So if you have an EGFR mutated lung cancer that is stage 3 and has not progressed, so initially upfront, we're still doing definitive chemoradiation therapy with platinum-based chemo and radiation field as needed, and then you follow it up with osimertinib, and the progression-free survival is amazing. Now I think we are almost in the realm of talking about definitive, treatment upfront with these patients. So we don't wait until progression. These are actually patients that disease has not progressed, right? So initially, as you all know, I think we treated with chemo XRT and we wait. And we surveil these patients with PET scans and CT scans. And if things have progressed, sometimes we go back and retest tissue. This is the time when you get a call, can you go back and do an ion, or go back and see this PET positive FDG avid area. And I've done like 3 of these cases in the last 2 weeks. But now this data has come, they have not progressed. Should we just put these patients on osimertinib without even progression? So I think that is very, very exciting data. It's called the LAURA trial. If people are interested, just look it up. And I thought this was pretty phenomenal data. It just came out in the ASCO meeting a few months ago. I think this was just in November. So role of the pulmonologist, right? So what do we do? Why should we know about a little bit of this oncology stuff? And should we just do the biopsy and send them on their way? Well, first of all, biomarkers are moving towards lung nodule risk stratification. So very much in the diagnostic realm. The ones that are available, you really have to understand how to use it to derive any benefit from them. Things like the nasal swab, and I think these are only going to increase in number. And you have to kind of, as a pulmonologist, start to understand their use it appropriately, and then interpret them appropriately. The most important part would be, am I interpreting these in the appropriate manner I should? And give them the level of importance as part of data gathering, and see if the data is aligning together. I would not recommend hanging your hat on just the result of one biomarker test, because that might lead us down a pathway where other data that is screaming at us may not be as obvious if we have that approach. So use the biomarkers and risk stratification of lung nodule to guide your diagnostic evaluation, but among other things. Obtain adequate tissue. So that is important. It has always been important. And now with not just ION, but NOAA and other competitors, there's a lot of competitors in town. But robotic bronchoscopy as such has changed the landscape. I exclusively use that particular one because it's available to me. But I have been exposed to others in the past as well. So whatever system you use, focus on getting enough tissue for PD-L1. Consider doing EBUS upfront with your diagnostic evaluation of a lung nodule. Stage 1B to stage 3A, 3B non-small cell lung cancer. Think about biomarkers in these patients. Should I implement next-gen sequencing at the time of slide, when the pathologist calls me, at the time of the slide call that says definitively looks like non-small cell lung cancer. And it kind of saves the patient some time. By the time they go set up with an oncologist and have their blood drawn, it's probably another 10 days. And you could have the result back if you intervene at that point. So I am trying my best to see how I can implement this. It's been challenging, but if you're able to, I would recommend discussing that with your team as well as oncology. And the workflow is going to be quite important to see how you're going to order this biomarker testing and how you would consider reflex next-gen sequencing testing, whether it's in your Bronx suite or in your clinic. For me, the workflow for biomarker testing has been working out because I do have a dedicated nurse navigator for the lung nodule program, and we decide during the initial clinic visit, and the result comes back in about 7 or 10 days. I get an email about it, and if I think it is relevant to the patient and changes the plan, then we call them right away. If not, we inform them of the result, but we will discuss that at the next visit. So patients are always kind of looped into how that information is being used. Now, stage 1B or greater non-small cell lung cancer, in my opinion, needs absolutely comprehensive biomarker testing. Some of this is not implemented yet in the guidelines, but I do think that's going to change very quickly. And I think serum-based testing is complementary to tissue-based testing. So absolutely, there's a panel of 7 different biomarkers that have to be sent for non-small cell lung cancer from your tissue. And then serum-based testing, mostly driven by oncology, would then be complementary to that. Consider coordinating with your oncology teams, and that would be the best thing I would advise to start. Some people I know are already successfully doing this, and they have decreased time to staging an appropriate treatment plan with actionable mutations in the neoadjuvant and the adjuvant setting. So those are critical for us as a pulmonologist. That's about it, and I will take any questions.
Thank you, Dr. Pillai. That was great. Really important talk. I really felt like I learned a lot, and I'm sure the audience felt the same way. There are a couple of questions. One question I do see is, when do you always send the CDT and the XL2 together, or how do you manage that workflow? Do you think about it in specific patient circumstances?
Sure. I think, that there are options where you can decide which one you want to send on the forms. And basically, I try to separate those. Sometimes automatically both of them get sent. And we have to kind of like, pedal back and see which one is more useful in that case. But I think they're just very different tests. If you think that your pretest probability is going to be high enough that everything else in your mind is going against lung cancer, but your Mayo Solitary Risk Calculator says something like 24%. A lot of us would, still hesitate at 24% to just do surveillance. So at that point, I think we have only two things available to add to that data point. Well, I'm going to do my Mayo Solitary Pulmonary Risk Calculator or Brock model, whatever you use, and then I'm going to get a PET CT scan. Which may, especially if the patient says, I don't know about general anesthesia and this whole procedure, I do get a PET CT scan on those lung nodules, and then you would use a biomarker testing. So I wouldn't hang my hat on just one of those, but I'm looking more for alignment of data. So if I'm thinking the risk is enough that I would consider, but everything else about the patient is not in alignment with that, or it's a patient shared decision-making request to say, is there anything else you can tell me that this is possibly not cancer? Usually my first answer is no. There is absolutely no way we can say that. There is no 100% in medicine, but you use that data and that. So that's a patient I will send Notify XL to. The Notify CDT, again, the reclassification to over 65%, I will say maybe there is one case I've really seen in 3 years of using these tests where I was like a little surprised, and I'm like, all right, it was about 35%, and it came back not over 65%, but it came back in the 40s. So not a terrible change, but it did alert me to say, should I go back and do something different for this patient? So it did elevate. I think it went from the 20s. So we were kind of in the and those are also days when I did not have a robot. So it was the old radial EBA style of doing the bronchoscopy procedures, but about 22 to 25% risk, and I think it went up to 40s. It did alert me, and we did end up getting a PET scan which showed a cold nodule. So more rare of a test. But Notify XL2 might prevent some procedures in patients where you're kind of ambivalent, but use it, again, in alignment with other data.
I definitely agree with you. I think XL2 is a pretty powerful test, especially with the negative predictive value, and especially in patients who may be hesitant to get a bronchoscopy or any procedure for that matter. I just had a elderly woman today that I saw in clinic, and she has been on the fence about getting a biopsy, and I'm considering XL2 as well. One question I had with the use of XL2, you mentioned getting a follow-up scan in about 8 weeks, 2 months time period. Do you ever wait till the 3 months, or you usually are on the shorter end of the surveillance?
I think it really depends on what the pretest probability is. So if I'm more in the teens and it looks like the patient has, valley fever, exposure in the past, things like that, then I just stick with the 3-month guideline. If there's a little bit of nervousness, and you can sense it during the appointment, moving it to 2 months, it's not part of a guideline. But if there is a growth, I might be able to catch it a little bit earlier and intervene almost immediately. And these are nodules that are under 10 millimeters, and I'm usually having these discussions. So if it's 8 millimeters and I'm like, well, if it goes up to 10 in 2 months, we're still kind of not, waiting for the stage to advance. So it's really that stage discussion. And I bring up all of that with the patient.
Definitely. We do have another question as well. Are you currently using plasma-based biomarker testing at time of diagnosis or the call in the room?
So the plasma and the serum-based testing, I'm not using it. It's very oncology-driven here, and they want to really wait until the patient comes and sees them. But I think that, if that shifts and you can work with people where you can send it right in the bronchoscopy suite and your oncologist will be okay with it, I absolutely would recommend that. Because if you're part of the same system, then that's a great way to do it. The system that I'm with, and employed with, we have 9 hospitals, but there's probably 5 or 6 different oncology large groups. There's probably one predominant one that I have discussions with, but you know, they have their own workflows that are set in the outpatient setting. But honestly, I think that that needle does, you know, need to move in our community. There's about a 2 to 3, you know, week wait lag, and every day matters for these patients. And really, I think I'm actually surprised because the time to diagnosis varies so much from different parts of the country, and that really has to change. I think that's going to change when we move the needle a little bit and say, I'm going to start to send these. You may have to give a little push. You're going to definitely going to get a lot of pushback, but you may have to push back also and say, well, I have a confident call. I know this is cancer, and I know this was an adenocarcinoma call. Then, you know, just send it.
Yeah, so for just from our background in our practice, oftentimes it's just one extra blood draw logistically. If you're part of the same system, then you just have to be cognizant that you're doing one extra blood draw at the time of diagnosis. So generally what we would do is once we get a call in the room, we ask for next-gen sequencing at the same time. Previously, we would do a blood draw and send it for serum-based testing as well. So I think it does really help the patient and the oncologist to find it helpful as long as you have a working relationship with them, you've had this conversation with them, and they know what to expect. I think it's really makes it seamless for the patient as well, because when they present to the oncology appointment, oftentimes a lot more information is available for them.
Yeah.
I guess another question that I see in here is, has the use of biomarker testing XL2 CDT changed your use of PET scanning, the use of PET scan?
I think that's a great question, because setting up a PET scan and doing it is, again, you know, if you're part of one system, it may seem easier, and it did for me for about 5 years, but now it really isn't. And so I'm seeing turnaround times of at least 2 weeks to get a PET scan. That is a great outcome if I have PET scan back within 2 weeks. So I send the notify at the time of the clinic appointment. Reasonably, I've been getting the result back within 7 days, if not earlier, usually day 6 or so. So if it really, you know, reclassifies things to absolutely benign, and my gut feeling was this is a cocci nodule, you know, if the PET scan's really delayed, I think I usually just change it to a CT scan at follow-up, which is about 2 to 3 month timeline. But I think that if the patient needs all of the data during the clinic appointment, and I've discussed that, you know, well, it is going to tell me something about the activity. Again, these are nodules that are between, say, 8 to 10 millimeters and borderline. The PET may not be very useful. So I use the Notify XL2 in those patients. If you're talking about a 14 millimeter, 15 millimeter nodule, the PETs will give you some information. So I kind of order both at that time.
Great. I don't see any other questions here, so I want to take the opportunity again to thank you again, Dr. Pillai, for an excellent talk. I also wanted to let the audience know that we really appreciate their attention, and that to tune in and stay plugged into the SAB website. We'll be having new and exciting changes coming up soon. Thank you again, Dr. Pillai.
Thank you so much for the opportunity.
Yes, thank you on behalf of the SAB. Have a wonderful evening, everyone.